carpal tunnel syndrome. If somebody gets tingling numbness in the hand, the first thing when I was an orthopedic resident was shortwave diathermy, cervical collar traction. This cervical spondylosis. Before he has said the second statement, the diagnosis was already made, this cervical spondylosis, and this was the treatment. No relief, okay, you are malingering. And you go to for MRI. No, things have changed. It's a common neuropathy in not too far distant, just about a generation earlier. Somebody did 2 operations with somebody who had tingling in the hand and said this is carpal tunnel syndrome, and now this 2 has gone magnified into 2 to 4 lakhs per year in a country like America with a very thin population. Our country probably will be seeing much more, but we make a mistaken diagnosis of cervical spondylosis. It's very common in females, not that males are immune. Night paresthesia, tingling in the night, patient waking in the middle of night, and they're shaking their hands. And so see nicely a female shaking their hand and 3 o'clock in the morning. This is a classical carpal tunnel syndrome. Pain is not the carpal tunnel syndrome. Patient said I got pain, you are looking at some other radial, ulnar and central pain. So it is not pain, it is tingling. I'll ask them a second question, is it pain or tingling? They'll modify it, no, it is tingling. So we are looking at tingling. So you flex the wrist and keep it flexed for half a minute till the symptoms are precipitated. You press between the flexor carpi ulnaris and palmaris longus, keep it pressed for half a minute, patient gets tingling in the hand, in the fingers. Do you feel the person who is going to give you nerve conduction study is going to give you better results? How often times the neurologist is doing this examination? It is often that, almost always that it is the technician who is doing the examination and neurologist is just signing without even seeing it. Do you think you know less than the person who is showing the report? So no, you be the boss, you be the captain of the ship, and you make the diagnosis based on clinical examination and not the report, which may be misleading. So gold standard nerve conduction is not an appropriate word, because it can again be positive and negative, and this can give you an erroneous diagnosis. The other tests, ultrasound and MRI. Yes, I have identified okay, this sonologist is going to do a better job than the other, so my preference is to send to it, irrespective of the fact the patient, why you are sending to this person only. That's his problem of thinking, but he'll tell me this is the diameter of the median nerve, proximal, distal, and this is what I am seeing. A French study said electrical study is not indispensable. That means it is dispensable for diagnosis. So do you have to do it? You really don't have to do it. Once you have made a diagnosis, you need a differential diagnosis. Is it related to thyroid? Is it related to vitamin B12 deficiency? Or is it post-viral? How many patients post-viral? We have a spate of viral diseases, dengue, chikungunya. So many people, lakhs of people were lost. COVID. It can be side effect of antihypertensive. One hand surgeon was talking to me. He was ready to undergo surgery, and he just started reading amlodipine. He said, "Oh, side effect of amlodipine is tingling in the hand." He stopped amlodipine, shift to something else, and the tingling numbness disappeared. So it can be a side effect of one of the medicine. And if this is not the end, there are far more number of medicine. We'll talk about it. And you see the tenderness in the upper part of the forearm, and it flex the middle finger actively against resistance. If the pain says ouch here, you are looking at median nerve getting compressed more proximally. This is a pronator teres syndrome, and against the proximal, we'll talk about it again, against the proximal edge of the pronator teres, against the proximal edge of flexor digitorum superficialis, the nerve is getting compressed. So this is pronator teres syndrome. As well, this patient will have an altered sensation where the palmar branch of the median nerve is going to get altered, and sensation in the thinner area will also be altered. So this is pronator teres. If you have made the diagnosis based on your clinical examination and supportive tests like nerve conduction or ultrasound, conservative management. You can give a splint, steroid, relaxation. A splint for 3 weeks to 1 month to 1.5 months, intermittent use, and definitely during rest and definitely at night. Local injection, single shot is good enough. If this is not working, you require a surgery. What kind of splint? There are splints which are small, which are medium size and they are large size. So it should cover about 2/3 of the size of the forearm, and strictly don't need a hyperextension, you don't need acute flexion, it has to be neutral. Use it during daytime intermittently and continuously at night time. What kind of steroid? Water soluble. Local hydrocortisone better than placebo. Local injection, no oral. Temporary, even for 2 days. If the patient say I am better, that means this is almost confirmatory, this is carpal tunnel syndrome. It has therefore a good prognostic sign, and if the symptoms are again coming back, good indication for surgery. How many injections? 1 is okay, 2 no, 3rd absolutely no. Diabetes, the patient is not going to be benefited in long term. Who are the patient who will fail? A diabetic is very likely to fail. A senior person is likely to fail. If the symptoms are severe enough, symptom sensation has changed, thinner muscles have started to waste, they are candidates who should be operated early. So what are the indications for surgery? Failure of conservative management, if the sensation is affected. If acute carpal tunnel, acute compartment syndrome, of course they need surgery. What if the tests are normal? You've done carpal tunnel syndrome, electrophysiologist says it's normal. American Society for Surgery of Hand would perform carpal tunnel release in face of normal electrodiagnostic test if cortisone temporarily resolved symptoms. So try injection if the patient present this way. So we had a patient, a doctor's relative, came from another city, and electrophysiological tests were normal. The rheumatologist said, no, this is a rheumatological condition, you require methotrexate. Now there is a dilemma. What do we do? I said, give a steroid local injection. The symptoms vanished for 4 days and they came back. So though all the tests were not supporting a clinical diagnosis of tingling, numbness, night paresthesia, but hydrocortisone injection, local single injection, elevated the symptom for a short while, then they came back. So this patient was operated with good recovery. So hydrocortisone local single injection is good test for reconfirming if the tests are not in your favor. There are multiple ways of describe for operating this. What I do is the incision is lined with the ring finger. Why here? Because this on the radial side is the median nerve, on this is the ulnar nerve, and this is the dividing line between the median and therefore the nerve fibers are the thinnest here, and therefore the damage to the terminal branches is going to give you the minimum amount of residual pain in the long run. The point is, having made the incision, you go in and it should be wide enough that you put your scissor superficial to the flexor retinaculum and again deep to the flexor retinaculum, and after undermining both the superficial and deep to it, you should be able to cut the superficial fascia here, and then be able to insinuate your finger in the distal inch of the distal forearm. So this is deep to the flexor retinaculum, and you cut the retinaculum. So what you see here is not only the median nerve, but you see how angry looking it is red. In addition, you excise all the synovium. The big advantage of doing synovectomy is patient gets a better range of motion. Now, not only that, very important, first time patient extend the finger, it's very painful. Encourage the patient to do the movement right there then. Tomorrow it's going to be more difficult, and third day it's going to be very difficult. And therefore encourage the patient. The first movement may be painful, second may be painful, but third the pain is eased. And therefore encourage the patient and encourage the movements, and the movements will be there forever. So the finger should be able to insinuate, and you can do a lot of synovectomy of these patients. How much should be the distal release? The distal release till you cut the flexor retinaculum, and suddenly you start seeing the fat here. So that is a level to which you should release distally. If you make your incision more ulnar, you are fine. But if you make it more radial, you are likely to damage this, and this will become very painful. And therefore keep your incision in line with the ring finger, and you are fine. So this is the one who got pain on the radial side now. Post-operatively elevate it, move the fingers and splint for 2 to 4 days so that the medial nerve does not translocate more superficial to lie under the skin. It should remain deep, and 1 to 2 days, even 2 days is good enough, so that the superficial something has started to form, and then move the joints. Suture removal in about 2 weeks. Don't be in rush because the skin is thick and does not heal very fast. So 2 weeks Maybe even extra 2 days is not going to make a world of a difference, but earlier removal, like the 10 days you remove as rest of the places, can put wound essence. If the diagnosis is pakka, then next morning the patient will say, wow, why I didn't undergo the surgery for such a long time. So prognosis is very good. Patient recover extremely fast. It's in extremely rewarding condition. So in summary, diagnosis is clinical, night symptoms, tingling numbness. Very important statement I am making now. Look at the patient. Patient's gesture is telling you the surface anatomy of a nerve. The patient said, I have got tingling on the radial side. Patient is telling you, I have got median nerve. Patients got tingling on this side. Patient is telling you, I have ulnar nerve problem. Patients, I have a radial pain. Patient is telling you, I have a radial nerve problem. So look at the patient gesture. They are telling you the surface anatomy of a nerve. In spite of everything, surgery can fail.